host this evening's event. It is entitled The Surgical Management of Epilepsy in Pediatric TSC, but these are issues that are, I think, relevant, and I can say this confidently as an adult neurologist. They are relevant to adults with TSC as well. I'm happy to, our speaker is Dr. Nabavi Nouri, who is an associate professor in pediatric neurology with appointments in the Department of Pediatrics and Clinical Neurological Sciences at the Schulich School of Medicine and Dentistry, and adjunct appointments in departments of Neuroscience and Epidemiology and Biostatistics, all at Western University in London, Ontario. Among her numerous clinical activities, she leads the comprehensive TSC and epilepsy genetics clinics at London Children's Hospital and serves as one of the provincial leads for the Ontario TSC network. Fantastic network that I'm glad exists because it's a great group to collaborate with. I'm not in Ontario, I'm in Quebec. And Dr. Nabavi Nouri is particularly interested in advanced diagnostics, therapeutics, and the transition of care for adolescents with epilepsy. So I'll leave it to you, Dr. Nabavi Nouri.
Thank you, Michael.
There you go. Thank you.
Thank you. Thanks, Mark. Thanks for the introduction. So I will just proceed with some. So we're going to be talking about the surgical management of epilepsy, like you mentioned in TSC. It's pediatric focused, but it wouldn't. It really is would serve across the board. I thought I'd just start with just some facts about TSC and epilepsy burden. I know through our educational series, we've had many of them, many of these facts repeated, but overall, epilepsy is a big portion of patients with TSC. About 80 to 90% of TSC patients experience epilepsy, and majority of them are present in the first year of life. A special form of epilepsy called infantile spasm is reported in up to 50% of our patients, and over 2% are drug-resistant epilepsy, which just means they are resistant to the first and second line medications. So you most of the time end up using more than 2 or 3 anti-seizure medication. And as it also has been stated before, patients with epilepsy have a strong, TSC has a very strong neurodevelopmental impact, such as autism and intellectual disability, all under the bigger umbrella of TAND. So surgical, there has been a kind of data on surgical underutilization, despite great evidence. And so here we are wanting to talk about where surgical stands in management of TSC patients with epilepsy. Some historical perspective is that TSC has been traditionally considered as a poor surgical candidate because of the fact that they're believed to have, they do have multiple cortical tubers on MRI, so multiple potentials for potential sources for seizures and epilepsy. Their EEGs are usually diffuse and multifocal, and they have what is called early onset spasms, which is known to just be driven by a very diffuse network. And outcomes historically have been variable because of an incomplete localization. So as a result, there is under-referral, delayed referral to epilepsy surgery programs, and a majority of patients with DRE, despite having DRE and having to go through multiple anti-seizure medications, are often delayed in being considered for surgical for epilepsy surgery. And the contemporary shift is really driven by some advanced diagnostics, such as advanced imaging, high resolution MRI and PET. But that aside, the one thing that's really changed the field has been the use of stereo EEG, and also our understanding of the epileptogenicity of the tuber and the perituberal area. And also understanding TSC as a network disorder. So this is kind of it feeds into the conceptual shift that is a network-driven disorder and not purely lesion-based. And although you have multiple tubers, that doesn't mean that you have multiple independent foci, multiple independent sources for epilepsy. And we know this through works of stereo EEG that although you can have a very rapid propagation and very wide network engagement, but it can often start very focally. So our goal is always to identify a dominant epileptogenic network or a node with secondary hubs and try to be able to kind of disrupt this critical, disrupted node from the network. And so that's why there's been kind of a paradigm shift from removing the visible lesion to targeting the epileptogenic circuitry. So really an objective of our review today is to define the challenges in pre-surgical evaluation as every patient who is undergoing epilepsy surgery goes through a pre-surgical phase and then is the actual surgical intervention. And we're going to talk about some different methods that is being now used. One is sort of the good old resection of the tuber, but now we do have the laser interstitial thermo therapy and stereo guided radiofrequency ablation. I will talk to, I know I have a few abbreviations here, but we'll get to talk about it all in detail. And then, of course, just applying the network-based decision framework to our clinical cases. Most patients most patients go through a pre-surgical workup, and the pre-surgical workup is quite standardized. And of course, if when you're dealing with patients with TSC, where you have a multifocal tendency for seizures, it may mean that their journey may be longer and there may be more additional tests that one needs to complete before they are determined to be a suitable surgical candidates. So we generally start with a scalp EEG. I must say these are the investigations, but it really all starts from patients and their semiology and what their seizures look like. And then, of course, the next first step is the scalp EEG, where you may find multifocal spikes, which again means multifocal seizure tendency. You may find very diffuse patterns such as hypsarrhythmia in patients with infantile spasms. Or you may also have focal ictal onset identified in about, half of the patients. And that ictal onset is key. So despite having multifocal seizure tendency, which is known as interictal discharges, the ictal onset and how lateralizing and localizing it is, it really determines kind of the trajectory of the network. And then next comes, high resolution MRI. I must say, even with 1.5 Tesla MRIs, there is tubers are generally picked up very nicely on both 3T and 1.5. However, having a 3 Tesla MRI and higher resolution allows one to better identify the margins of the cortical tubers. And so we often not only see the cortical tubers, but there's also the transmantle-like features, and FCD-like perituberal cortex. So these are all features that help us really categorize the lesions, and also there have been some evidence in terms of grading the FCDs based on their intensity on T1 versus T2, and some data on which tubers may be more epileptogenic compared to the other. And PET, good old PET, has been around for a very long time. However, the FDG PET that is a particular dye is very glucose based. That is not known to be highly, highly sensitive and specific to TSC. There is another another form of PET called AML, which is not very readily available. It's more specific for patients with TSC. So it may help lateralize when MRI is not very clear. We do use other tests such as MEG. And also SPECT. Those are all the only kind of ictal perfusion study is SPECT that we use when we are unsure which tuber is really the driver of the seizures, because there could be, again, like I said, a bigger network, and there could be overlapping tubers that our semiology and EEG may not be able to help us really nicely localize. So the goal of all the pre-surgical workup is to define a surgical target. So we really are looking for multimodal concordance to increase the likelihood of seizure freedom. We really like to understand the ictal onset, which really feeds into the network hypothesis I was alluding to earlier. We like to understand whether we're talking about one single dominant driver versus multiple interconnected nodules, which, nodes or tubers. And of course, surgical feasibility, whether, the tuber is easily accessible by resection or whether we need to think about some minimally invasive techniques such as laser or radiofrequency ablation for deep or eloquent tubers or tubers that are very close to the eloquent cortex. And of course, we know that there are a few prognostic factors such as younger age at the onset of epilepsy, shorter duration, epilepsy duration, and greater extent of the epileptogenic zone. And also, the further away you are from the eloquent cortex, we know that the extent of the resection can be enough to lead to a surgical freedom, post-surgical freedom, epilepsy. And so, a very recent paper looked at some surgical outcome in children with tuberous sclerosis. This was published into 2025. And interestingly enough, as you can see through looking at all comers, and this was a the systemic review of looking almost at 600 patients. The Engel class 1 was reported in about up to 66% of the patients. And the Engel class 1 is the classification that's used to define and categorize post-surgical outcomes. This really only focuses on seizure and seizure freedom. And so an Engel class 1 essentially means patients who've become completely seizure free. And then ranging from Engel class 2 to 4 means recurrence of part, like shorter or smaller part of the seizure. Sometimes it's just the aura. Great, and it based on the extent of seizure recurrence, whether it's part of the seizure or full seizure recurrence, and the frequency of the seizure, that the grading changes from 2 to 4. And so grade 4 is a poorest seizure outcome, and that is reported in actually only up to 10% of the patients. Now, what's interesting in this systemic review is that they looked at in some factors such as number of tubers, which they identified that the highest and strongest predictor of seizure freedom was when you have less than one tuber, and the odds of a seizure freedom was up to 5 times more. So it's a very strong predictor of seizure freedom. However, interestingly enough, in patients who had no cognitive delay or mild cognitive delay, there was a lower likelihood of good outcome. And also, if you had no intellectual abnormality and sort of counterintuitive, what we may think in clinical practice, if you only had one focus on EEG, they found that these were not really associated, these were kind of not associated with better outcomes. And preoperative IQ essentially had very minimal clinical effect. And interesting for me, as I'm interested in the population with infantile spasms, that patients without infantile spasm had a lower odds of a good surgical outcome. So their whole premise of the paper was that if you have a more severe course, meaning you have a higher cognitive burden, higher developmental delay, more multifocal discharges on EEG, or even presence of infantile spasms, essentially a more severe profile of epilepsy was associated in a way with a better surgical outcome. It's almost like there's more to save as opposed to when you are already on a milder trajectory. There appears to be less to save, so to say. And by saving, I mean a brain function. So this is kind of an interesting paper, but we'll of course have to take it into consideration of many other features. But what I found particularly interesting is that we are always looking for very clean EEG where you have one focus, and we often think that having a one focus and more concordant data is always associated with better outcome. They just showed that having a cleaner EEG was not particularly associated with better outcome. So now in terms of surgical modalities, there is the open resection, whether you would go for a tuberectomy, which is just removing a tuber, or lobectomy, you remove the lobe that contains multiple tuber. It is considered to be more invasive. You have laser interstitial thermal therapy called LIT. This is MRI guided laser, minimally invasive. It's for deep and eloquent cortex. There's also parallel to that stereo EEG guided radiofrequency ablation, which is known as thermocoagulation. The benefit of this is it allows you to understand the networks better, because as you have implanted the patient with stereo EEG, you can use the radio frequency ablation to modulate the network, and it almost has an adjacent role to the diagnostic and an extra additional arm for some diagnostic purposes, and it can of course have some therapeutic benefits as well. And then another one is really an integrated approach of perhaps starting with the stereo guided radio frequency ablation and then moving on to a open resection. So there's certainly a lot of room for stage and hybrid strategies. So what I'm going to do now in the next few minutes is that I'm going to talk about a little bit about background of each modality, and then talk about a few cases. There's been quite a few systemic reviews. This is, of course, a high area of interest. One of the first systemic reviews that came, it was particularly looking at the role of resection in patients with TSC, and this was a multi-center pediatric cohort that looked at about 75 children and who presented with TSC with median age of 10 years. All underwent a multimodal pre-surgical workup that we already reviewed. The intervention was really tuberectomy and plus or minus extended perituberal resection. They also found the Engel class 1 was reported up to 65% of the patient in the first year, and then Engel class 1 was also maintained up to 50% in the second year. And so again, talking about the important role of resection in patients with TSC. So with that, I'd like to talk about three different kind of scenarios and three cases. So this is a 5-year-old girl who presented with a focal to bilateral tonic seizures. Seizures started very early on at 3 months of age. What we like to see is kind of the variety of different seizure types, and this patient only had one, did not have spasms, and was treated with multiple anti-seizure medication, including a ketogenic diet. Patient was confirmed to have TSC2 on MRI, had multiple tubers, subependymal nodules, was diagnosed with drug-resistant epilepsy, also had other features of TSC, such as the confetti lesions, bilateral small renal cyst, and was diagnosed with autism. So her pre-surgical evaluation showed that she had focal discharges over the right frontal head region, had multiple seizures identified coming from the same tuber, although the interictal discharges were very multifocal, coming from different parts. MRI confirmed multiple tubers. Actually, we also completed a MEG that showed multiple dipoles, but the dipoles were mostly centered around the right frontal head region. So this is to show you the MRI on the left-hand side, and we're looking at two different modalities from an axial cut, where we can see on a T2 flare sequence, we can see multiple tubers. Following that, there's a kind of a GAD T1, which doesn't show much. However, the one on the right is showing you a post-surgical resection. Now, this patient, again, we are seeing an epoch of the EEG that showed seizures that appear to be very diffuse in onset, however, were mostly right frontal predominant. Patient underwent an stereo EEG coverage. And for those who don't know, these are electrodes that are put within, so they are positioned within the parenchyma of the brain, and what it does is that it allows you to be able to target the epileptogenic network in a three-dimensional way. So by covering the area of focus, you're able to really plan the stereo EEG around tubers and the hypothesized network. So it gives you a great ability to understand the seizure very close, up close and personal. As you can imagine, a conventional EEG is very limited in its coverage, although it covers the whole brain, but it is limited by space and by coverage, as well as there is perceived to be multiple barriers multiple barriers of the dura, the skull, the skin, and also if the lesion is deep within the brain, you only are able to see kind of, some subtle changes or very diffuse changes, which is the case here. Whereas if you put in a stereo EEG, you're able to really localize and hone down the localization. So this patient underwent a tuberectomy that was guided by the stereo EEG, remained seizure-free after 18 months in follow-up. However, she remained on vigabatrin. She improved both intellectually and behaviorally, and her interictal EEG also just showed very rare abnormalities overlaying the tuber. I want to say if there were any questions, please feel free to interrupt. I'm going to move on to the second case. This is an older girl. She was diagnosed very early on, actually antenatally. That's how usually the patients can be diagnosed through a cardiac rhabdomyoma that was picked up on an echocardiogram in the second trimester. So patient was born with a high suspicion of TSC. MRI also revealed multiple tubers, and patient was noted to have a de novo mutation in TSC1. And the neurological symptoms had appeared very early as daily focal right-sided seizures, and also the patient was also diagnosed with infantile spasms, but they were noted to be asymmetric spasms. And just like the first patient, she had been tried on multiple seizure medication with very partial response. So this patient on her MRI was noted to have a very predominant tuber, as you can see on the right side, that sits over the left parietotemporal head region, and we were able to and the patient was able to be identified to have seizures coming exactly from the tuber, and this tuber was very easily accessible. The data was very concordant, so the patient underwent a direct resection. So in this case, there was no implantation with the stereo EEG. Everything was concordant, and she underwent a direct resection, which is another a way of approaching more obvious concordant cases. And after surgery, she again had an angle class 1 for several years. And this resection was done at 8 months of age, so very early on. And now we're talking about this is an 11-year-old girl. So she remained seizure-free for 9 years. However, the seizures did come back when she was 11, and her EEG showed multifocal abnormalities. And the patient, because of that, was able to go back on vigabatrin and became seizure-free. So this is really a case where the surgery allowed her developing brain to experience many years of seizure freedom, not being on any anti-seizure medication. It allowed her to catch up on her development, and so even when the seizures came back after 10 years, she was able to go back on anti-seizure medication and become seizure free. A third case is about a patient, again, a young girl, presenting with focal seizures. Her seizure semiology was very peculiar, a high likelihood of the seizures coming from a part of the brain that's very deep within the frontal lobe called the orbitofrontal gyrus. So she had multiple seizures that was captured during her EEG admission, but also we identified seizures coming from the opposite side, but they were noted to be subclinical. So this is again another case where, despite having seizures coming from two different sides, it's still worth exploring this patient for epilepsy surgery in that we may be able to give her, provide her with seizure freedom from the most disabling seizures. And these were all nocturnal seizures for her, while we quote unquote tolerate the subclinical seizures that are coming from the opposite side. She also was noted to have a TSC type 2. She had a hypometabolism coming from the right orbitofrontal tuber, which again confirms that is the most epileptogenic tuber. And she underwent a stereo EEG with bilateral coverage, more on the right compared to the left. And this again is showing just her stereo EEG coverage and the tracing from her stereo EEG recording. But seizures were all being localized to the tuber that you can see at the bottom of the page. And while there were numerous seizures coming from the right side, there were a rare subclinical seizure coming from the left. So she underwent a tuberectomy over the right side, which was the source of many of her habitual seizures. And then, and despite having had seizures coming from the left side, it was left untouched and intact. She may be down the line if that becomes more of a if it becomes more symptomatic and she start experiencing clinical seizures, she may be amenable to kind of minimally invasive procedures down the line, but that wasn't thought to have been the case. Now, in terms of the surgical minimally invasive therapies, we talked about laser, which is the interstitial thermal therapy. Both laser and radiofrequency ablation are on a basis of a physical principle of thermoablation or thermocoagulation and in denaturization of the tissue proteins, which begins if there is the temperature is increased beyond 50 degrees centigrade, and if this is applied for a few seconds, this could lead to essentially a disruption of the network. LIT in particular is really used for patients with hypothalamic hamartomas. It's been now explored in TSC and other malformations of cortical development, and very rarely non-lesional cases. And so this is sort of a bit of an overview of how, a comparison between laser interstitial thermal therapy and stereo EEG guided thermocoagulation. So both are really used or regarded as minimally invasive techniques that target deeper lesions that are not accessible to resection. And also the pathophysiology and the technique for each is different to the other. So while one is a stereo EEG guided targeting, the laser is mostly predominantly targeted through a real-time MRI thermographic versus a stereo versus radiofrequency ablation, which is stereo EEG guided. And so the targets are usually the lesion in laser, but it's mostly network driven in radiofrequency ablation. The invasiveness is considered to be very kind of comparable between minimally invasive to very minimally invasive. Seizure freedoms are noted to be higher in patients undergoing LIT treatment versus stereo EEG guided radiofrequency ablation. And the role of the radiofrequency ablation is really diagnostic plus therapeutic, and it's often used as a bridge to resection versus laser could be a standalone treatment that's offered to patient. And the biggest limitation is that with LIT, you have a limited ablation volume that needs to be taken into consideration versus with stereo EEG. You can target wider networks, and you can that's kind of an advantage of radiofrequency ablation to laser. I'm just going to skip over this. This was kind of a very small case series talking about 3 pediatric patients who underwent LIT in patients who have TSC, and they were reporting a meaningful seizure reduction in almost 2/3 of the patient. Majority were experiencing Engel 1 classification and significant reduction in anti-seizure medication. and there were no preoperative complication reported. And it is a very important factor in majority of our patients that the minimally invasive techniques are associated with very lower number of complications. So we are on case 4. And so this is a patient with, again, similar to our second last case that was diagnosed with cardiac rhabdomyoma. The patient was born with a very big noticeable tuber. For some reason, majority of our patients are having right frontal cortical tubers. This patient also again had a right frontal tuber, and there was kind of a very progressive nature to her course with a explosive onset of seizures that started by focal seizures, and then it evolved to having up to 8 to 10 seizures per day and increasing in frequency and duration. Very quickly failed up to 6 anti-seizure medication. And pre-surgical data showed concordant MRI finding and EEG confirming that seizures were coming from the same tuber. And so there were, discussions about whether she would be a case for open resection versus MR guided lit. And given the fact that she was very young, the decision was made to proceed with a laser lit therapy for her. And so, as you can see, this is sort of showing you the actual margins of the lesion, and what you see on the right side is the lesion before ablation, and what you see, sorry, on the left side, and then what you see on the right side is the lesion after ablation. So this led to significant improvements. The patient began to crawl, developmentally made significant improvements. She was seizure-free for 5 months postoperatively, but then began to develop a new seizure type with head shaking and jerking movements. And so this led again to further investigations, and again in consideration of perhaps a more resective, more resective option for her. But given how young she was, the team had proceeded with lit first, and then consideration of a resection down the line. So our last technique is this stereo EEG guided radiofrequency ablation. So this is thought, like I mentioned, to be used mostly as a therapeutic, but also diagnostic. And patients that undergo radiofrequency ablation are known to have a higher chance of seizure recurrence, especially in comparison to resection and lit. So this was a small study looking at 9 children with TSC who underwent stereo EEG guided radiofrequency ablation. They were actually noted to have a good complete seizure remission up to 90%, but in a short span of time at 6 months. And actually some were able to maintain that seizure freedom up to 1 year of age. However, like I said, we know that the chance of seizure recurrence are quite higher for patients that undergo radiofrequency ablation. And this is another case to demonstrate a young patient who started with infantile spasm, transition from spasms to focal seizures. She experienced daily seizure with a semiology that was localizing to an area of a brain called insular opercular onset. And for those of you who don't know, the insular cortex is really in a very vascularly rich area of the brain, and sometimes it's considered a dead zone for neurosurgeons to access the insular cortex through an open resection. And so based on her workup, the decision was made to, given the fact that this is considered a deep vascularly rich region, to proceed with stereo EEG coverage and ultimately offer a stereo EEG guided radiofrequency thermocoagulation. And this is showing seizures coming from the coming from the insula on the left side, and after an ablation, you see kind of the resolution of the spikes. So just to understand sort of the algorithm for surgical approach in patients with TSC, it's really to identify a focus, but we don't stop there. It's identifying a dominant zone and then understanding whether we have concordant or discordant data, and then is to progress to identifying, kind of understanding the network, that this is really the turning point, that epilepsy in TSC is network driven, and stereo EEG is really essential to really define the seizure onset, map propagation, identify the dominant nodes, and then this really determines everything that follows. And what follows is really selecting the best approach based on the data that you have gathered through the stereo EEG, whether the patient would be a good candidate for resection, lit, or radiofrequency ablation, and of course considering a staged approach always, and kind of personalizing the approach based on the data that you have gathered from the pre-surgical workup. So really the take-home message is that the TSC is a network disease, and the seizure generation can extend well beyond an individual tuber. And it is stereo EEG is critical for precision to define the seizure onset, propagation, and network hierarchy. And surgery must be considered in all patients with TSC, in my opinion, and also must be personalized with match intervention to patients' network architecture. Thank you. And with that, I will stop there. I'm happy to take any questions.